Thank you so much for joining me today. Today we'll be talking about nursing fall assessment of patients with movement disorders. By the end of this lecture, you will be able to define what are falls, discuss three categories of falls, understand standardized assessment tools used to identify patients at high risk for falls, understand nursing intervention and fall prevention, and discuss ongoing nursing monitoring to prevent falls. Before we begin, we have to start by identifying or defining what really is a fall. So fall is when unintended event becomes real, resulting from a person coming to rest on a ground or a floor, wall, or any other surface. This includes witness or unwitnessed reported by the patient's falls. According to Morse, inpatient falls can be classified to three categories. Accidental falls, which are derived from extrinsic factors such as environmental consideration, cords laying on the floor, cluttered room, floor not being even, slippery socks, those kind of things. And anticipated physiological falls that are derived from intrinsic psychological factors such as confusion, agitation, and unanticipated physiologic falls, which are derived from unexpected intrinsic events such as new onset of syncopal event or major intrinsic events such as stroke. So why are we talking about falls in patients with movement disorders? Well, research shows that patients with movement disorder are at higher risk for falls, especially patients with movement disorders such as ataxia, Parkinson's disease, Huntington's disease, Tourette syndrome, and other that are also considering at high risk for falls. Risk factors here usually include impaired balance or coordination, rigidity, and slow movements, sudden repetitive movement, decreased coordination that leads to unsafe behaviors. Serious falls can lead to numerous injuries, including head injuries, broken hips, and other bone fracture. Complications from these injuries may require hospitalization or long-term rehabilitation, and some falls can lead to death. So why nursing is really concentrating on falls and falls prevention? Well, first of all, nursing care foremost is about safety. And safety is often defined as a freedom from psychological or physical injury. Safety also refers to prevention of patient from injury. So we have equality and standards of education for nurses that in short is called QSIN. And this particular organization talks about safety competency for nursing and defines it as minimizing the risk or harm to patients and providers through both system effectiveness and individual performance. So obviously, since quality and safety education for nurses brings this goal to us, it is foremost important for nurses to make sure that patients are assessed and falls are prevented. Most falls are preventable. Fatal falls related to injuries should never occur while a patient is under hospital care. However, not all falls can be prevented, but neither they are inevitable. So research shows that approximately 20 to 30% of falls can be prevented by assessing risk and inadvertently to reducing the risk of falls. Nurses must assess all patient fall risk and place correct intervention in place so falls can be avoided. This will allow us to identify patients at high risk and lead us to choose appropriate intervention to prevent falls and maintain patient safety. We should encourage a culture of vigilant safety consciousness through continuous feedback and learning from adverse events. Assessing each individual event thoroughly and putting intervention in place should be important task of each nurse. It's part of nursing process in most of the hospitals, as each fall is individually reviewed during the reporting of falls, and then during the quality control usually reviews of those falls. Patients should be assessed for past medical history, visual impairment, agitation, confusion, medication risk, and those are just some factors that may also put patients at high risk for falls, especially during hospitalization. Each patient should be undergoing very thorough medical reconciliation, and consult with pharmacists should be done so medications could be reviewed, and specifically to avoid patient at risk for falls. As I mentioned to you before, falls are inevitable, but some of them can be prevented. We teach all the nurses that they should not attempt to stop the fall or catch the patient. Instead, they should control the fall by lowering the patient to the floor. Here is a very easy way to teach nurses how to try to catch and glide the patient down to the floor. Step number 1 is to catch the patient. The legs should be in a wide stand, and we should keep our back straight. Picture number 2 shows how we can glide the patient. Get ready to slide the patient down. Picture number 3 shows how we slowly lower the patient to the ground. Picture number 4 shows how we keep our back straight while we are lowering the patient. And last picture shows how we can support the patient's head so the patient head doesn't hit the floor. All of those motions are done with using a proper dynamics movement, so the nurse or a provider does not get hurt, neither the patient in this process. So you see that assessment of patient risk factors for falling is essential in determining specific needs and developing the target intervention to prevent falls. We'll be discussing 5 different tools that you can use to assess patient fall risk. Time up and go, TUG test, the 4-stand balance test, 30-second chair stand, Moore's fall scale, and Hendricks fall scale. So time up and go, otherwise called TUG, it's very easy assessment that can be done on each patient, and it's usually used as a resource for screening, assessing, and intervening with patients that are at fall risk. TAG is validated, measured, and recommended by CDC to screen individuals for fall risk. Time up and go test is designed to test mobility skills, balance, and fall risk in older person. This test requires that person stands from a chair, walks 10 feet, turns, and walk back to the chair and sits. Higher fall risk is defined as more than 12 seconds to complete the TUG test. Decreased time to test at post-testing indicates improvement. The fourth stage, a balance test. It's also a validated measure recommended by CDC to screen the individual for fall risk. This test is used to assess patient balance. Patients should begin the test by trying to stand, by starting to stand on both feet side by side. Each position should be remain for 10 seconds. So the nurse will tell you when you're supposed to begin changing the positions. If you can hold your arms out or move your body to help you keep the balance, that's okay, but you are not allowed to move your feet. So again, for each position, the patient should stay at least 10 seconds, and the nurse will allow them, let them know that the position can be changed by saying stop. So the first position is again standing with 2 feet by the side. The second position is when the patient is supposed to place 1 foot, so it's touching the big toe. The third step is the tandem step, which is placing the foot in the front of the other, so the heel is touching the toe. And then the fourth position is when the patient stands on 1 foot. If the patient maintains this for 10 seconds or more, then they are successful. If they are standing in a position less than 10 seconds, indicates failure, thus making them at risk for fall. "30-second chair stand" is another tool that is used by CDC. And this particular tool can help you screen and assess the intervene to reduce your patient fall risk as well. This test is assessing lower extremity strength and endurance, and the person starts by sitting in a sitting position and crossing their arms on their chest, then standing and sitting repetitively for 30 seconds. Use of hands to stand is a 0 score, and a greater number of raises in 30 seconds as a post-testing indicates improvement. Please make sure that the chair is at least 17 inches high and that you do have a stopwatch to make sure that a patient is repeating this for 30 seconds. Now here we see a Morse fall scale. It's composed of 6 different assessment. We're starting with the history of falling. Patient is answering yes or no. Secondary diagnosis that can put them at risk, usually is 0 for no and 15 for yes. If the patient is using any ambulatory aids such as crutches, walker, furniture, anything like that, it's counted as 0, 15, or 30. Intravenous therapy such as an IV or even a heparin lock, that's usually again positive, so we're adding 20 points here. 5 is gait, so we're going to look at normal and bed rest or wheelchair, weak or impaired. So usually if it's normal or patient is using a wheelchair is 0. If it's weak, we're going to say 10. And if it's impaired gait, then we're going to mark them as 20. Mental status, if patient is oriented to its own ability, that means 0. But if we see any kind of forgetfulness or any other overestimation of safety, we will mark this patient as 15. So for this total score, for this scale, if the patient is more than 45, we will say that the patient is at high risk. Anything 25 to 45, we will say that the patient is at moderate risk. And anything below 25, it will mean that patient is at lower risk for falls. The Hendricks scale is also intended to use in adult acute care, ambulatory assisted living, and long-term care facility, and population health settings that any kind of adult is living and potentially at risk for falls. The Hendricks 4-2 scale was originally validated in a large case control studies in acute care settings, but since then it has been evaluated in different settings as well. For this particular tool, you need further permission from the Hendricks Fall 2 team before you can use it in your electronic health platforms, or use it as a documentation form. So this form here is just used for educational purposes. Please do not copy that and distribute it for any other purposes as education in this document. This particular scale is asking similar question to Morse scale, such as confusion, but it's also adding a symptomatic depression that makes patient for risk, altered elimination, such as Foley catheter, is also adding a points to putting patient at risk, dizziness or vertigo. Study also showed that males are at higher risk for falls. So here in this tool, that's added to this particular assessment. This tool also is looking at specific medications such as anticoagulation and benzodiazepines. So if the patient is using one of those, they will be included as well in this test. The other two tests that I discussed previously, like get up and go, as well as chair stand, are being used here as potential scores, as potential points to evaluate patients at risk. A score of high or greater, it already is defined as a high risk. So patients that are at score 5 or greater should have implementations of potential fall risk modification done in their patient chart. It is very important to understand and implement interventions for the patients that are at high risk. I will briefly mention a few of the interventions in this presentation. Number one, the prevention that is important includes environmental, and this can be done by repositioning the patient frequently. Sometimes we do use alarms. That is just to let the staff know or the nurses know that the patient is getting up and maybe needs assistance, especially for those patients that are forgetful. Here you can also implement a sitter at the bedside to help the patient have someone there if they do need to get up. Sometimes we can implement a low bed. Low bed allows us to have the patient lower to the floor. So if the patient rolls off the bed, the impact of fall is not as bad. Sometimes the low bed is also combined with the floor mats, and floor mats help, again, decrease the impact of patient falling. Another thing that we can do with helping prevention here is decrease stimulation. So maybe decreasing the amount of people going in and out of the room, making sure that the TV is not too loud, the music is not playing, so the patient does not get agitated or have a decreased amount of stimuli coming from the outside. It is important here to say that decreasing stimulation is important, but lighting should always be considered, as a fall risk as well if it's poor. So making sure that the lights are on, or at least when the pathway from the bed to the bathroom is lit, so the patient doesn't, tumble on something and stuff like that. Here also, it's important to mention reducing clutter in the room and making sure that the room is clean, getting the cords off the floor, any kind of equipment that it's in the way. So that should be a nursing responsibility to maintain patient room being neat and organized. Some other intervention that the nursing can do is called a diversion activities, and those are rather simple, do not really require a lot of fundings, but conversation, having a patient, having someone to talk to, that they can be distracted, watching video games or videos in general. Sometimes for older patients that are confused, Legos or folding towels could be a good task to do, as they can just sit on the side of the bed or somewhere and just have towels folded or play Legos, watching television, and obviously ambulating. We do have a tendency of putting alarms on the patient and saying to them, sit down, sit down, sit down. And sometimes a little ambulation goes a long way, and patient can kind of use their energy and then sit down and watch some TV. But we should address patient ambulation as one of the diversion activities. Obviously, any patient that is at fall risk should have ongoing monitoring, and the monitoring should include patient comfort. Nurses should make sure that the patient is not hungry, that they are not thirsty, that they don't have a need of going to the bathroom. Range of motion activities should be done at least once a shift. This is also reducing the risk of patient, agitation and confusion, and helps with keeping patient satisfied so they don't try to get up without help. We should assess patient mental status and cognitive functioning, and try to reduce the level of distress and agitation by, intervention or medications if possible. Patient safety, again, is foremost the most important. Vital signs should be assessed, as vital signs can also be put patient at risk for falls. We should do frequent circulation checks, skin integrity, and obviously environmental checks such as clutter, wires, and furniture to make sure that the environment is clean. Thank you so much for listening. My next slide is just references. Please do not hesitate to email me if you have any questions. Again, thank you so much for having me today. Have a great day.